Welcome to the Module 1 of Severe Acute Respiratory Infection, or SARI, Treatment Facility Design. Module 1 provides an overview of basic operational and infection prevention and control principle in COVID-19 context. By the end of this lecture, you will be able to describe the public health objective at all stages of preparedness and response plan, identify ventilation and exhausted air treatment as IPC measure within a COVID-19 context, and explain the different mode of transmission and apply a rational use of PPE. The modules is organized in 3 different sections. First is public health objective and strategic priority by scenario, ventilation and exhausted air treatment as IPC measure, and mode of transmission and rational use of PPE. Currently, countries are experiencing one or more of this epidemiological scenario. Country with no case, country with 1 case or more, imported or locally acquired. Country experiencing cluster of cases in time, geographic location or common exposure, and country experiencing larger outbreaks of local transmission with community-based transmission. Major intervention should be put in place immediately and then scale up according to the epidemiological scenario. For the first scenario, country with no case, country should set up screening and triage protocol at all points of access to the healthcare system, including primary healthcare center, clinic, hospitals, emergency unit, and ad hoc community setting, and set up COVID-19 designated wards in existing healthcare facility and prepare for the next scenario. For the second scenario, in addition to screening and triage facility, country should designate specific COVID-19 treatment center in order to admit all the possible cases and prepare for the next scenario. With the third scenario, with cluster of cases, country should then surge by repurposing ward or intensive care unit into COVID-19 wards and hospital, identify and designate community facility for isolation of mild and moderate cases, and plan for new structure to augment the health system capacity. For the first scenario with transmission at the community level, country should then set up new hospital or in temporary structure or permanent structure to augment COVID-19 patient care. It can be a new construction or through repurposing an existing building into a treatment center. The referral pathway changes well according to the different scenario. During the introduction and localized transmission scenario, suspected COVID-19 patient can be identified at primary care screening and referred to the hospital where a dedicated COVID-19 ward has been designated. When reaching the community transmission scenario with the opening of a dedicated SARI treatment center, the referral pathway changes accordingly, and all suspected and confirmed COVID-19 patients will then be referred to the treatment center. Where health facility can no longer manage patients with mild or moderate disease, isolated patients who are not at risk for severe disease, people younger than 60 years old with no comorbidity disease, either in community facility like stadio, gymnasium, hotel or tent that can be repurposed into community facility with access to rapid health service via adjacent dedicated COVID health post, telemedicine, or at home according to WHO guidance. Surge capacity is the ability of a health system to meet an increased demand for health service. It is dependent on a well-functioning incident management system and entail human resource management, especially staffing, supply, equipment, logistic and resupply mechanism, specific expertise for critical area of care, and overall management of hospital resources such as expanding space and premises. Planning for surge capacity should allow for progressive scale-up of activity over several stages with clearly defined activation threshold for each stage. A severe acute respiratory infection treatment center flexibility and extension plan should be an integral part of the surge capacity, moving from a severity categorization to a cohorting approach as well, enabled to quickly respond to changing transmission dynamic and increase the total bed capacity. If needed, big facility can be used to set up cohorted wards for severe and critical patients. Existing building can be repurposed and prefabricated facility adapted to meet the minimum required in order to use it at SARI treatment center. The purpose of ventilation is to provide healthy air from breathing by both diluting the polluant originating in the building and removing the polluant from it. Building ventilation has three basic elements. Ventilation rate, the amount of outdoor air that is provided into the space, and the quality of the outdoor air. Airflow direction means the overall airflow direction in a building, which should be from clean zone to dirty zone, and air distribution or airflow pattern. The external air should be delivered to each part of the space in an efficient manner, and the airborne polluant generated in each part of the space should be also removed in an efficient manner. There are three different methods that can be used to ventilate a building. Natural ventilation, where natural force like wind drive outdoor air through the building openings such as window, doors, a solar chimney, wind tower, and trickle ventilators. Mechanical ventilation, where mechanical fans drive mechanical ventilation. Fans can either be installed directly in window or walls or installed in an air duct for supplying air into or exhausting air from a room. And then a mixed, the hybrid ventilation, which relies on natural driving force to provide the desired design, flow rate, and it can use mechanical ventilation when the natural ventilation flow rate is too slow. The decision whether to use mechanical or natural ventilation for infection control should be based on needs and availability of the resource and the cost of the system to provide the best control to counteract the risk. However, if the stable specific ventilation and exhausted air treatment system are proposed for each one of the service or area existing in the treatment center. Airflow should always move from clean to more dirty zone and in a top-down direction in order to reduce the risk of nosocomial infection. Using a air extractor will easily allow for control of the ventilation rate, meeting the air change per hour standard required and assuring a constant unidirectional top-down airflow. In warm climate country, due to temperature and pressure, the airflow will naturally move to the opposite direction. For this reason, it is essential that the air extractor is turned on whenever there is a patient in the room. Air from the room can be exhausted directly to the outdoor, where the droplet nuclei will be diluted in the outdoor air. It's essential to exhaust the airway from air intake vent, person and animal. If, for any structural reason, dilution is not possible, exhausted air should pass through a special high-efficiency particulate air filter, HEPA filter, that removes most of the droplet nuclei. HEPA filter is a type of plated mechanical air filter. It is an acronym for high-efficiency particulate air filter. This type of air filter can theoretically remove at least 99.97% of dust, pollen, mold, bacteria, and any airborne particle with a size of 0.3 micron. In order to simplify the installation, reducing the construction time, and assuring proper air treatment, facility may benefit from the use of portable HEPA filter unit equipped with the proper fitting ducting to exhaust air from a selected room to create the required ventilation flow rate and exhausted air treatment as well. Another option is UVGI, is ultraviolet germicidal irradiation. is an electromagnetic radiation that can destroy the ability of microorganisms to reproduce by causing photochemical change in nucleic acids. UVGI is not recommended as a standalone system, but only as complementary of API filtration in case of higher recirculation. Because the clinical effectiveness of UV system may vary, UVGI is not recommended for air management prior to air recirculation from airborne isolation room. It is also not recommended as a substitute for HEPA filtration, locus of air to the outside, or negative pressure, but as a complementary system only. The traditional epidemiological model holds that infectious disease results from the interaction of agent, host, and environment. More specifically, transmission occurs when the agent leaves its reservoir or host through a portal of exit, is conveyed by some mode of transmission, and enters through an appropriate portal of entry to infect a susceptible host. This sequence is called chain of infection. For infection to spread, all these links must be connected. And infection prevention and control goal is to break the link in the chain to prevent the transfer of the pathogens. An infectious agent might be transmitted from its natural reservoir to a susceptible host in a different way. There are different classifications for mode of transmission. COVID-19 transmission can occur through 3 different modes. Direct contact, which occur through direct physical transfer between a susceptible host and an infected person, or through indirect contact, which refers to a personal contact between a susceptible host and a contaminated intermediate object, usually inanimate. Through droplet by inhalation of infective large particle via close contact with an infected patient sneezing or coughing. Or airborne, but only when performing aerosol-generating procedures such as tracheal intubation, non-invasive ventilation. COVID-19 is not an airborne virus, but can be aerosolized during this specific medical activity. The current global stockpile of PPE is insufficient, particularly for medical masks and respiratory. The supply of gun and Google is soon expected to be insufficient also. Surging global demand, driven not only by the number of COVID-19 cases, but also by misinformation, panic buying, and stockpile, will result in a further shortage of PPE globally. In view of the global PPE shortage, the following strategy can facilitate optimal PPE availability: coordinated PPE supply chain, use of PPE appropriately, and minimize PPE needs. Within a COVID-19 facility, this strategy can be implemented through the use of physical barrier to reduce exposure to the virus, such as glass or plastic windows, as shown in the image. This approach can be implemented in area of the healthcare setting where patients will first present, such as triage area, the registration desk, and at the emergency department or the pharmacy window where medication is collected. Administrative measures as well, such as restricting healthcare workers from entering the room of a patient if they are not involved in direct care, considering bundling activity to minimize the number of times a room is entered, for instance, checking vital signs during medication administration or have food delivered by healthcare workers while they are performing other care, and plan which activities will be performed at the bedside.